So when a patient has come to you, you've diagnosed them with diabetes, at the same time they have hypertension. How do we choose antihypertensive in a diabetic patient? This video is good for medical students and those who want to learn medicine. Let us see the main goals in diabetic hypertension. Now, in diabetic patient, treatment is not only to lower blood pressure, but to reduce cardiovascular risks, that is stroke, MI, protect kidneys, that is prevent diabetic neuropathy progression, and also avoiding metabolic worsening. When I talk about metabolic worsening, I mean glucose, lipids, electrolytes. Now, this is the first line drug of choice, the core the ACE inhibitors or ARBs, angiotensin receptor blockers. These are the foundation therapy. When I talk about ACE inhibitors, I mean captopril, enalapril, lisinopril. And when I talk about angiotensin receptor blockers, I mean losartan, valsartan, telmisartan. Why are these the first line antihypertensives in diabetes? One, they reduce intraglomerular pressure, they reduce albuminuria and proteinuria, they slow progression of diabetic kidney disease, and they reduce cardiovascular mortality. However, this is a caution. Use one of them. Use either ACE or either ARBs, not combining them, because they both work on the RAS, renin angiotensin aldosterone system. Step 3 is the stepwise approach to treatment. So start with ARBs or SCIs, especially if diabetes plus hypertension, microalbuminuria or proteinuria, CKD if not contraindicated anyway. Now in step 2, add a CCB, a calcium channel blocker. That is in case BPs are not controlled on the first line. And the most preferred is amlodipine because it is long acting. Why are they second line? They have stronger BP control, they have neutral effect on glucose and lipids, and they work well with the SCI or ARBs. If not controlled, we can add a diuretic and preferably a thiazide diuretic. That is hydrochlorothiazide or indapamide. Why? It is very effective in salt-sensitive hypertension and works well in combination therapy. But please, this should be a last choice. Avoid the thiazide diuretics. And even when it is to come, it should be a very small dose. Because thiazide diuretics, one of their side effects is hyperglycemia and also increase insulin resistance. So it is not even mentioned in most of the guidelines. It comes in as a last choice. We have nothing to do, but it should never be on the forefront in managing hypertension in diabetic patients, because of tendency of causing hyperglycemia, can cause hypokalemia, and can increase uric acid. Let us avoid the loop diuretics like furosemide, just in special cases, for example, heart failure, fluid overload, CKD, but not a routine antihypertensive.